Hi, good evening. My name is Kimberly Hendricks. I'm presenting today for a group that I would like to incorporate called Improving Diabetes Outcomes with Integrated Behavioral Health. This group is going to be a medical visit program for adults with type 2 diabetes and depression here in rural Tennessee. I know this is something that our local community has asked for help with, and so this is a presentation of a group that I would like to integrate and work with primary care on doing. So first, we're going to talk about the population that we're missing out on. So this is adults ages 30 to 70 living with a type 2 diabetes and significant depressive symptoms here in the rural Tennessee areas. Um, there's a lot of challenges with this happening, and so we're going to discuss today some of those challenges and how we can make them easier. So depression affects the person's motivation for lifestyle change. It affects how they adhere to their consistency on taking their medications. It also nutritional choices and emotional eating. Here in rural Tennessee, nutrition is a big deal, also because of the poverty level and issues with healthy foods. And so we want to talk about lifestyle change and looking at healthier ways to eat. We're also going to talk about physical activity and daily movement, sleep quality and stress regulation, follow-up appointment attendance. Then additional rural barriers that we need to talk about is going to be the limited access to behavioral health here in the rural areas, transportation challenges for people to their appointments, financial concerns and underinsured, fewer specialized mental health resources, social isolation, and just distrust with the healthcare um, community overall. So the reason why this is going to be important is not only are they getting their traditional primary health care, they're getting those brief visits, their labs as they needed, but we know that the primary thing here is also how their mental health has been affected by their diabetes. And so we're talking about depression. Depression is fairly common with this. So we're going to address not only their medical, but also their behavioral factors together. So you may ask, well, what's getting in the way of us doing that? So that could be that there's not enough of that in the community. Traditional primary care visits are like 15 to 20 minutes. That gives you enough time to do their A1C, adjust their meds, reinforce recommendations. But with adults with type 2 diabetes and depression, maybe there's not enough evaluation and assessment of those, and also how they may need more intensive care when it comes to behavioral health. So here's my proposed solution in us doing integrative healthcare to provide that. So we're going to start with a 6-week integrated behavioral health shared medical appointment program. And what that means is we're going to take a group size of 8 to 12 patients. We'll have weekly 90-minute sessions with structured clinical interventions. This is not just education. This will be held here in the primary care clinic. Each session is going to be led by a coordinated team of different specialists. In my initial plan, an outline that I provided for you all today, it talked about how this is going to include the primary care provider, the DBH, behavioral health clinician, a dietitian, a pharmacist, and even maybe an exercise or movement specialist that can help clients understand physical activity. The program goals are going to improve improve their glycemic A1C, also to reduce depression, strengthen their diabetes management, enhance their quality of life, and reduce unnecessary healthcare utilization. So quickly, what's going to happen over those 6 weeks? In week one, we're just going to do like a connection go, work on introductions, rapport with each other, what the expectations are going to be in the group, baseline assessments, and individual goal setting. Week two, we're going to look at nutrition, emotional eating. We're going to talk about strategies for that. We're going to work on emotional eating patterns and behavioral activation. Week three, we're going to talk about stress and CBT strategies, stress management tools, cognitive behavioral strategies to reframe unhelpful thoughts. And then week four, we're going to have someone come in and help us with physical activity and movement because that's very important for these clients. Then lastly, at close to week five, we're going to talk about medication adherence, affordability, adherence strategies. And then the last week, week six, we're going to reassess using all those assessment tools. We're going to do some long-term planning, go review, relapse prevention, resource connections if needed, and then be able to just do a monthly maintenance type program or telehealth follow-up. So success is going to look like this. First of all, using all these 6 weeks programs, combining all these providers together, it's going to show through the baseline PHQ-9, their diabetes stress and scale, their A1C, how all of these things hopefully are going to improve by week 6. Medication adherence rates, the patient's progress towards individualized self management goals, and then also just hopefully seeing good attendance, satisfaction surveys that we will do at week 6 on exit interviews. And then overall, that'll help us to keep statistics of evaluating how well the program's working. So, why this benefits the patients and also our practice. Integrated behavioral health care creates meaningful and measurable value for both the patients and the practice. So, by addressing the medical and behavioral barriers together, this program is going to deliver outcomes that traditional primary care visits are just not doing right now. And this also is going to help us to be able to show efficient care delivery to multiple patients simultaneously. It's going to improve engagement and appointments attendance, early indication of any behavioral barriers. Maybe there's more even in the mental health, behavioral health field that the DBH can help provide and then work on with that client after their 6 weeks. So, why does your team need a DBH such as myself? So, a DBH is a doctor of behavioral health provider that brings specialized expertise not only at the intersection of physical health, but behavioral health in the healthcare system. So, we're going to be able to uniquely position the bridge gap between the medical and then their behavioral change. We are able to administer all the different assessment tools and to help you with the PHQ-9, distress, even see if there's any trauma or emotional issues that could even be, causing this to be a further problem for them after the 6 weeks. We're going to deliver brief evidence-based interventions with clinical settings. We're going to apply our cognitive behavioral therapy needs and any other tools that may be needed. Motivational interviewing will be really important. And then we're going to coordinate that care with all of you on the multiple disciplinary team. And then lastly, we track behavioral and critical outcomes to show success in the program. So the DBH's critical role is translating medical recommendations into sustainable daily behaviors going beyond what patients know to address why change feels possible. So the decision I'm asking today of all of you is, do you not see how important that depression and diabetes are, and that they're not just separate problems, that they do come together and they interconnect? And so with this 6 week shared medical appointment program that's led by all of us and includes myself, this will offer a structured and evidence-based path forward for rural adults who are currently falling through the gaps. So I'm just asking for three specific commitments. That's protected staff time to plan and implement this pilot program, leadership and support for patient identification and referral pathways, and then access to evaluate the expertise to measure outcomes and demonstrate the impact. So hopefully also providing an area here at the clinic where we can have the groups and again to show success for not only the patient's overall health, but also statistics and data here for the clinic. So I'm available for further questions if you have any at this time, and I would love to hear feedback on this. Thank you.